Hello. So, good evening, everyone. Today, we are going to discuss about initial assessment and stabilization of a neonate that we are going to receive in casualty as a pediatric surgery resident. So, the basic funda that I'm going to discuss is like I will discuss all the soft points. Then, I have few conditions that I'm going to discuss, and there will be the few conditions that will be remaining that I will discuss as a separate topic in upcoming videos. So whenever we are getting a neonate in casualty, the first and the foremost thing that we have to take care of, that there is a continued diligence is needed to maintain homeostasis and to achieve further resuscitation. So we will talk on few points. So the first thing is, जैसे ही आपको नियोनेट मिला, हैंड हाइजीन इज द foremost and important thing that is going to save millions of your neonates if the hand hygiene and the overall hygiene is maintained, because this is the inciting point which is going to start the chain of damage. Then the second, we will talk these 10 points. So the temperature maintenance is very important thing. There should be a neutral thermal environment, and we have to take care of the normal temperature that should be in a neonate is 36.5 to 37.5 का जो रेंज होता है उसमें होना चाहिए, और हमको उसको अचीव करने के लिए वी हैव टू डू ऑल मेजर्स. वी विल डिस्कस दिस पॉइंट. I'm just narrating them down, and then we will discuss it separately also. Then we have to look for evaluation, and also if we found that there is any sort of problem, we have to sort out that problem. We have to support. So the airway management is the key component, then oxygenation, anemia, and ventilatory insufficiency. Then the third thing is cardiovascular status. The fourth thing is establishment of venous and arterial cannula. We have already done the part of temperature management. Then we looked for the respiratory, then CVS. तो अभी तक आपका बच्चा जब हमने थर्मोजेनिक्स या सॉरी बच्चे का जो थर्मल एनवायरनमेंट है उसको हमने देखा, उसको हमने मैनेज किया, उसको हमने वी ट्राई टू सॉर्ट इट आउट. तो तब तक बच्चे को हम नॉर्मल उसमें ले आए. तो नाउ आवर ड्यूटी इज़ टू टेक केयर ऑफ वीनस एंड द आर्टीरियल कैनुलास दैट विच इज़ नीडेड. वी विल लर्न लेटर. So then afterwards, acid base balance, followed by the initial laboratory evaluation that we will do. It includes CBC, LFT, RFT, and blood culture, and then blood gases wherever required. Then X-ray studies and special studies for diagnosis and management. Then the next step is sepsis prevention and treatment. Okay. Then followed by nutritional maintenance, and then organ system functioning related to newborn physiological immaturity. We will discuss all these points one by one. So what happens when you are going to receive a baby or a neonate in casualty? So like a baby is transported from a certain distance. It might be 10 kilometer, it might be 20 kilometer, it might be 50 kilometer, it might be 100 kilometer or 200 kilometer, depending upon where you are working, whether it is a tertiary center, whether it is a CHC or a district hospital. Okay, so whenever baby becomes cold, there will be increase in the metabolism. It will lead to oxygen demand कि अब जो ऑक्सीजन की डिमांड है वो बढ़ जाएगी, जितनी सप्लाई हो रही है उससे ज़्यादा बढ़ जाएगी. तो इस वजह से नाउ द बॉडी विल स्टार्ट डूइंग एनारोबिक मेटाबॉलिज्म विच विल कॉज एक्युमुलेशन ऑफ लैक्टिक एसिड, एंड दिस विल फर्दर कॉज पेरिफेरल vasoconstriction, and the neonate will end up into hypothermia, hypoxia, acidosis, vicious cycle. And if we will not prevent from this thing, and we will not interrupt this cycle, so The protection from the cooling is the essential first step in maintaining circulatory and cardiorespiratory normality. So we need to take care, we have to have all these either incubator or radiant warmer or heated mattress or overhead heat shields or increased room temperature. So this is the measures that we can take. So that is we have to take care, and the constant vigilance is by monitoring the baby, that the whatever measures we have taken should followed judiciously. And then evaluation and support of respiration. While we are warming the baby, we should not forget the other steps in the in entire management. So we have to look for whether the airway open, that means there is no pooling of any secretions, there is no other problems. Then whether the baby is breathing well or not, whether the oxygen reaching the blood or not, whether the ventilation is adequate or not. So if we will delay in recognizing all these key points, child might end up into respiratory failure. Again, the hypoxia, acidosis, vicious cycle will happen, and there might be cardiac arrest and death also. Then the clinical assessment will include the general appearance of the neonate. We have to look whether at birth we do apgar, like how the like at 1 minute and then 5 minute and 10 minute. So that we have to look, that is regarding when the child is born, when the neonate is born. But when you are receiving that, you have to look for the general appearance कि बच्चा देखने में कैसा है, neonate कैसा है, whether the baby appearing pink, उसके पेरिफेरीज ठीक है, वार्म है, ठीक है, डिहाइड्रेटेड तो नहीं लग रहा है ना. तो डिहाइड्रेटेड देखने के लिए हमको उसका स्किन टर्गर देखना है, हमको उसका एंटी फॉन्टेनल देखना है, हमको उसका कैपिलरी रिफिलिंग टाइम देखना है. एंड देन वी हैव टू लुक फॉर डिस्निया, cyanosis we will look for the central and the peripheral cyanosis. And then we will look for airway obstruction. So airway obstruction can be because of some congenital anomalies, because of pooling of the saliva. So that we will assess, and we will do the further take the further steps. And then followed by, if we need arterial blood gas analysis, then we can do it. It's not easily available, especially not available even in the we have to struggle for it. Then why neonates are more vulnerable for respiratory compromise, for all these things? Because there is a reduced pulmonary reserve. We all know the development of respiratory system goes till 2 to 8 years. So your alveoli are still developing, so the reserve is low. Okay, there is a greater sensitivity to hypoxia, and this hypoxia, acidosis we have already discussed, and lactic acidosis का जो vicious cycle होगा, it will cause harm in your pulmonary circulation also. It will open the duct, the PDA, and it will cause further the baby will in the fetal state of circulation. So there will be frequent apneas, and then there are smaller airways. Then will come on the cardiovascular status. We'll look for the hydration status. बच्चा हाइड्रेटेड तो है, डिहाइड्रेटेड तो नहीं है, ओवर हाइड्रेटेड तो नहीं है, अच्छे से उसको फ्लूइड तो मिला है. We will look for all these, assess neonate for all these things. Then the peripheral pulses. And this pulse oximetry saturation screening is usually done after 24 hours of birth. This is basically to rule out any major congenital heart disease. What we do here, we do a preductal and a postductal SpO2 monitoring. So preductal and postductal, the difference should not be more than or equal to 3. That means we have to look for that difference कि वो इस रेंज के अंदर ही हो. and the separate SpO2 values, it should be 95 or equal to more than 95. So any factor, वो क्या हो सकते हैं फैक्टर? हाइपोक्सिया हो सकता है, एसिडोसिस हो सकता है, हाइपरकार्बिया हो सकता है, हाइपोथर्मिया हो सकता है, एंड इंटरस्टिशियल पल्मोनरी इडीमा. Because of all these things which are going on, it will increase the pulmonary vascular circuit resistance and it may reverse the fetal state of circulation. Okay, so and we have to be more aware while we are dealing with abdominal wall defects like omphalocele and gastroschisis, when there is intestinal obstruction secondary to atresia, malrotation, perforation, peritonitis, because all these fluid shifting will have pulmonary consequences that I have already discussed. Then the establishment of venous and arterial cannulas. अब आपका बच्चा हमने उसको नॉर्मल थर्मल रेंज में ले आए हैं, हमने उसका रेस्पिरेटरी सिस्टम देख लिया, हमने उसका CVS देख लिया है. Now we have to establish the venous and arterial cannulas. Venous cannulas we have to look for, है ना. So reliable arterial and venous access, it will enable us continuous hemodynamic monitoring, correction of the acid-base disturbances wherever required, and the delivery of fluids, blood products, vasoactive agents, and medication that is essential for perioperative optimization of the surgical neonate. Then acid and base balance. This is done for serial blood gas monitoring sick neonates, enables correction of acidosis, electrolyte disturbances, and also ventilation related abnormalities. जब भी ऐसे problem है तो we have to look for all these things to ensure about the physiological stability of the neonate before and after the surgery. Okay, then what are the radiological studies that we have to do? So we have to do a babygram. Here we will look for the radial abnormalities can be assessed, your chest and abdomen can be assessed. Then स्पेशल एक्सरे की अगर बात करेंगे, वेन एवर वी आर टॉकिंग अबाउट ARM, तो ARM में पहले तो इन्वर्टोग्राम करते थे, बट विद अंडरस्टैंडिंग एंड विद टाइम इट हैज़ बीन रिप्लेस्ड विद CTPL, दैट इज़ क्रॉस टेबल प्रो, CTPL बोलते हैं इसको, प्रोन लैटरल एक्सरे. ओके, तो वहाँ पर क्या है कि हम देखते हैं वेदर द ARM इज़ हाई और लो, है ना, उसके बेसिस पे वी हैव टू डिसाइड. बट देर आर वेन एवर देर आर टेलेटेल साइन, आपने कोई मिकोन्यूरिया देख लिया है तो यू कैन अवॉइड दिस थिंग. देन एक्सरे एब्डोमेन इंक्लूडिंग लैटरल प्रोजेक्शंस एंड चेस्ट एक्सरे वेयर एवर नीडेड, कॉन्ट्रास्ट स्टडी डिपेंडिंग अपॉन द कंडीशन ऑफ द और वट इज़ द सर्जिकल प्रॉब्लम इन द बेबी. देन हाउ टू, अब इतना सब कुछ कर लिया है तो न्यूट्रिशनल मेंटेनेंस की बातें भी करनी होंगी, क्योंकि बेबी is in totally new environment from transition from the intrauterine to the external world. We have to decide what is ideal fluid of choice, and that depend upon whether what is the which day of life it is, whether it is a preterm or a term child, term neonate, sorry. Then we have to also assess which surgical condition is baby having, whether there is associated with more losses, then we have to adjust, we have to correct. So for day 1 and day 2 it is usually dextrose only. Okay, for day 1 and day 2 it is usually dextrose only, and afterwards we add the sodium and potassium. So potassium is usually added when the baby pass urine once. Okay, then we have to be more aware while dealing with abdominal wall defects like omphalocele and gastroschisis, when the baby is having intestinal obstruction, when there is high OG outputs, and also we have to decide about parenteral nutrition. So parenteral nutrition के बारे में हमें डिसाइड क्यों करना है? हमें ये देखना है कि हम जब भी हम अपने सर्जिकल न्यूनेट, जब भी हम इस न्यूनेट को प्रिपेयर कर रहे हैं, वेदर दिस बेबी, दिस न्यूनेट विल रिक्वायर IV fluids or has to be NPO for more than or equal to 5 days. Okay. देन आती है बात प्रिवेंशन एंड ट्रीटमेंट ऑफ सेप्सिस. सो नियोनेटल सेप्सिस के बारे में मैं अलग से बात करूँगा. आई विल डिस्कस द रीसेंट WHO गाइडलाइंस, जहाँ पर वो हॉस्पिटल एंड नॉन हॉस्पिटल नियोनेट्स की बातें करते हैं. अल्दो देयर इज़ ए आर्टिकल वेयर दे डिस्कस अबाउट 0 to 59 डेज़ के नियोनेट के जो सेप्सिस हैं उसको इन नॉन हॉस्पिटल सेटिंग्स एंड हॉस्पिटल सेटिंग्स में कैसे हमको डायग्नोज करना है, हमको कैसे क्लिनिकल डायग्नोसिस कैसे होगी और फिर उसको मैनेज कैसे करेंगे. इट इज़ वेरी इंटरेस्टिंग. आई कैन अश्योर यू. आई हैव read this and I'll explain. It is very interesting. You will get to know like the practical problems which we often miss when we are in a tertiary setting, because everywhere you will not find the lab equipped with everything, है ना. So I will discuss in coming videos. So sepsis related जो mortality है is largely prevented with prevention of sepsis. So the hand hygiene is the utmost important thing. So it has been said that no matter whatever you are going to do, out of 10, like 3 to 4 neonate are going to die anyhow. आप सब कुछ कर लीजिए जो भी आपके पास मेजर्स हैं. So we have to be aware of about prevention of the sepsis, to timely recognize it, to rational about the antimicrobial use, antimicrobial therapy use, and the aggressive supportive care wherever it is required. Okay, then जो neonatal sepsis होता है उसको further divide किया गया है. early onset sepsis, that is depending upon the at or before 72 hour, and late onset sepsis after 72 hours of life. So there are risk factors that has been described. So if there is a spontaneous preterm labor in the absence of pre-labor rupture of membranes, that we will confirm while taking the history, whether there was any foul smelling liquor, whether there is any pre-labor rupture of the membranes more than 24 hours, whether there is any confirmed or suspected intrauterine inflammation, infection, or both of them. And even if there is a single unclean vaginal examination during the labor, and if there is a prolonged labor for more than 24 hours, including the stage 1 and stage 2, and if there is a severe perinatal asphyxia, that is अपगार स्कोर आपका less than 4 at 1 minute पे. लेट ऑनसेट की बात करें तो इट कैन बी आइदर a health care associated sepsis or a community acquired sepsis. When we are talking about healthcare associated infections, the risk factors are the prematurity, low birth weight baby, if a neonate requiring ICU admission, and if it is requiring mechanical ventilation, if there are presence of invasive lines and the neonate is on TPN. Then community acquired problems क्या हो सकते हैं कि पुअर हाइजीन है उसका, पुअर कॉर्ड केयर है, बॉटल फीडिंग कर रहे हैं, प्री लैक्टियल फीड्स. ठीक है, तो ये हमको वी हैव टू बी अवेयर ऑल दीज रिस्क फैक्टर्स. देन हाउ टू प्रोसीड, कैसे आगे बढ़ना है. तो जब आपके पास नर्सरी में नियोनेट आता है, एज इट इज़ ट्रांसफर्ड फ्रॉम आउटसाइड, यू हैव टू टेक ब्लड कल्चर्स and urine cultures wherever it is required. I'm not saying that it is universal. Blood cultures तो आप लेंगे. Then septic infants हैं, उनको आपको जल्दी रिकॉग्नाइज करना आना चाहिए. तो सेप्सिस वाला जो बच्चा है वो लेथार्जिक होगा, फीड इंटॉलरेंस होगी, है ना, इरिटेबल होगा, रेस्टलेस बेबी होगा. So you have to look for all those things. And these any neonate per se have immature immune defense because of it's not developed yet. एंड कहाँ पे हमको प्रोफाइलैक्टिक एंटीबायोटिक शुरू करनी है वो भी आपको देखना होगा. इन विच कंडीशन, लाइक इंटेस्टिनल ऑब्स्ट्रक्शन है, गैस्ट्रोस्काइसिस है, टेफ है ना, तो वहाँ पर आइनोट्रोपिक एंड वेंटिलेटर सपोर्ट वी हैव टू डू द अकॉर्डिंगली. देन व्हाट आर द ऑर्गन सिस्टम फंक्शनिंग रिलेटेड टू न्यूबॉर्न फिजियोलॉजिकल इमेच्योरिटी. वी हैव टू लुक फॉर न्यूरोलॉजिक, दैट वेदर द बेबी इज़ नॉट लेथार्जिक, नॉट रेस्टलेस, है ना. तो ये हमको देखना है. एंडोक्राइन में हमें देखना है कि बच्चा हाइपोग्लाइसीमिक नहीं हो. इतनी दूर से ट्रांसपोर्ट होता है, बच्चे को आई भी फ्लूइड मिला था नहीं मिला था ट्रांसपोर्ट करते वक्त, बच्चे ने कोई फीड लिया या नहीं लिया है, तो दैट वी हैव टू अवेयर ऑफ, है ना. कार्डियोवैस्कुलर हमने बात करी और रेस्पिरेटर की भी हमने बात करी. हिपैटिक हमें क्यों अवेयर होना है? बिकॉज यू हैव टू बी अवेयर because you are going to give few antibiotics that a few drugs that are going to eliminate either by a hepatic route or by a renal route, that you have to be aware, है ना. Gastrointestinal और urinary की हमने बातें करी. So now we are coming on the initial as we have that we have to resuscitate first and operate second. This is the main important thing. And then we have divided it into elective neonates, semi-urgent neonates and emergent neonates. तो इलेक्टिव नियोनेट की अगर आप बातें कर रहे हैं, ठीक है, इलेक्टिव नियोनेट की अगर बातें कर रहे हैं, सॉरी, like I'm coming, just wait for a few minutes. यार ठीक है, आप इलेक्टिव नियोनेट की बातें कर रहे हैं. सॉरी, तो हमने तीन उसको उसमें डिवाइड कर लिया है, इलेक्टिव नियोनेट्स, सेमी अर्जेंट नियोनेट्स और एमरजेंट नियोनेट्स. तो जब हम बोल रहे हैं कि इलेक्टिव नियोनेट्स, दैट मीन्स दीज आर द स्टेबल नियोनेट्स दैट यू कैन प्लान सर्जरी आफ्टर इवेल्युएशन एंड ऑप्टिमाइजेशन depending upon whether the surgery is really needed in this admission or at a later time after 1 week or so. तो एनोरेक्टल मालफॉर्मेशन है, कोई पेरिनियल फिस्टुला है, वेस्टिबुलर फिस्टुला है, whether the child is neonate is decompressing well or not, depending upon that you have to take your decision. स्टेबल सैक्रोकॉक्सियल टेराटोमा है, आइसोलेटेड इंटेस्टिनल अट्रीसियाज हैं. तो वहाँ पर आपको देखना है कि when they are stable there is no perforation, then in this case आप इनको assess करके fluid resuscitate करके you can post them on like after 24 hours. It's not like it is mentioned usually within 24 to 72 hours, है ना. So it's not like very rigid thing. You have to assess these babies. Then congenital diaphragmatic hernia, it is also like it's a physiological emergency, because I'll discuss this thing also. Then esophageal atresia है जिसमें TEF है या नहीं है. तो सर्जरी इज प्लान्ड ड्यूरिंग दिस एडमिशन आफ्टर स्टेबलाइजेशन एंड ऑप्टिमाइजेशन. देन सेमी अर्जेंट नियोनेट्स होते हैं. वहाँ पर क्या है कि जो आपके टैफ के बच्चे हैं, आपको सर्जरी करनी होती है आफ्टर एडिकेट स्टेबलाइजेशन. अट्रीसियाज हैं, मिकोनियम आइलियस है विदाउट परफोरेशन, मिकोनियम प्लग सिंड्रोम है, पाउच कोलोन स्टेबल जो बच्चा है, डुप्लीकेशन सिस्ट जो कि ऑब्स्ट्रक्शन कर रहा है, एब्डोमिनल वॉल डिफेक्ट्स हैं, आपने इनिशियल रिसिस्टेटेड कर दिया, बाउल कवर किया हुआ है, ओम्फेलोसील है विच इज़ इंटैक्ट एंड लार्ज, जेनेटो यूरिनरी है, आपने ब्लैडर ड्रेनेज कर दिया है उसको, मतलब आपने कैथेटर डाल दिया था पोस्टीरियर वाल्व में स्पेशली. हाइड्रोमेट्रोकॉल्पोज है, इनिशियल स्टेबलाइजेशन के बाद आप करते हैं. देन ऑब्स्ट्रक्टिव यूरोपैथी विच कैन बी ऑफ एनी कॉज. रेस्पिरेटरी एंड थोरेसिक प्रॉब्लम्स है, सिम्टोमेटिक है लेकिन स्टेबल है, एनोरेक्टल मालफॉर्मेशंस है. एमरजेंट नियोनेट्स में आता है कोई मिडगट वॉल्वुलस है. दीज आर द लाइक एग्जांपल ऑफ इंटेस्टिनल कैटास्ट्रोफ. तो वहाँ पर तो मिडगट वॉल्वुलस है ड्यू टू मैल रोटेशन, इंटेस्टिनल पर्फ है, एनईसी विद पर्फ है, क्लोज लूप इंटेस्टिनल ऑब्स्ट्रक्शन है, स्ट्रैंगुलेटेड इंटरनल हर्नियाज हैं. सो यू हैव टू like do something for these babies. These babies require immediate resuscitation. Abdominal wall, इसमें गैस्ट्रोस्कैसिस विद बाउल इस्चीमिया, कंपार्टमेंट सिंड्रोम हो गया, रप्चर्ड जॉइंट ओम्फेलोसील विद इविसरेशन, Then if there are like respiratory problems, टेंशन pneumothorax है, massive CPAM है जो कि cardiovascular compromise कर रहा है, ठीक है, जेनेटो यूरिनरी टेस्टिकुलर टॉर्जन हो गया, या फिर एनोरेक्टल हो गया, ट्यूमर्स हमने डिस्कस किए हुए हैं, जाइंट एससीटी विद हाई आउटपुट कार्डियक फेलियर, है ना, फिर अदर्स में गैस्ट्रिक परफोरेशन, गैस्ट्रिक वॉल्वुलस, मैसिव न्यूमोपेरिटोनियम विद कंपार्टमेंट सिंड्रोम. सो यू हैव टू रिमेंबर दैट यू हैव टू स्टेबलाइज फर्स्ट, identify the problem, decide the urgency, resuscitate thoroughly, operate at the right time. So better physiology, better outcome. So when we are talking about neonatal surgical emergencies, stabilization of these babies, it should be a family centered care. We have to be aware of newborn condition and plan of the care, to explain to the parents, and also कि भाई बच्चे को कौन सी कंजोनाइटल एनॉमलीज हैं, उसके साथ एसोसिएटेड एनॉमलीज क्या हैं, हम कैसे उनको वी आर गोइंग टू डील, एंड व्हाट आर द थिंग्स विच वी आर गोइंग टू डू. Then pumping and breast milk storage, that is important thing, recognizing and responding to the newborn cues. So the birth of a newborn with congenital anomaly is a crisis situation for the parents. Nurses should provide information, they should offer emotional support and facilitate the attachment, and this is our responsibility also. Then there are few congenital anomalies that present with respiratory distress. तो वो क्या हैं? So the commonest symptom of respiratory distress is restlessness. बच्चा जो है बहुत ही irritable होगा, restless होगा, and it will followed by tachypnea, retraction and cyanosis. So जब ये सब चीज़ें acute केस में होंगी तो this everything will occur so rapidly that we will not have sometimes time also, and it will followed by bradycardia and cardiac arrest. So importance of history and physical examination is a must, followed by chest x-ray, blood gas as per need, and passing an orogastric tube to rule out EATF. So now we will discuss one by one all the problems, and then we will get to know. So the first problem is there is a history of maternal polyhydramnios and the birth weight of 2.4 kg, which can be with or without congenital heart disease. Then there is a history of respiratory distress at birth, and also cyanosis with excessive nasopharyngeal secretions. So whenever this thing is there, we have to suspect that this child can have esophageal atresia with tracheoesophageal fistula. So we have to do the suction, proper suctioning, head up. We have to do 45-degree positioning of the baby. We'll discuss, and also do a chest x-ray with the 10 or 12 French red rubber catheter to assess whether there is a EATF or not. So prevention of hypothermia and workup, head up 45 degrees and prone to prevent aspiration. Along with, we have to do constant suction. We have to start antibiotics. If the baby required intubation, we have to intubate the baby. Fluid replacement and maintenance fluid, accordingly the hydration status of the baby and what is the which day of the life is it, and along with TPN. Then we have to do the 2D echo, and we have to rule out vectoral association depending upon condition of the neonate. Okay, then we will prepare neonate for the surgery. And the problem 2 is there is a history of progressive respiratory distress, and there is an antenatal history that you get to know that there is an antenatal diagnosis. You have to look for the chest x-ray postnatally. You have to put a orogastric catheter to rule out EATF, continuous monitoring with respiratory support. So this more or less suggests that there is some congenital respiratory lesion, which can either be a CPAM or it can be a CLO, that is congenital lobar overinflation, emphysema हो सकता है. तो surgical intervention depending upon the status of the baby, and usually we do a CT scan after 3 months of life, है ना. अगर immediate कोई distress नहीं है, तो उस पे देखने के बाद हम CT करेंगे, and then we'll decide what we have to do. Then if there is a history of sudden onset and progressive symptom of respiratory distress, for example if the neonate is on mechanical ventilation या फिर prolonged किसी को उसको bag and mask ventilation किया है, तो वहाँ पर आपको you will get the from nursery that there is a history of sudden onset and progressive symptoms of respiratory distress, and you examine the baby, you will find that there is a decreased breath sounds on one side, and orogastric tube is normally placed. You will meanwhile you can do a chest x-ray depending upon how severity is there, and you can do a bedside transillumination test. if this is like 1 centimeter के आगे आपका ये लाइट दिख रहा है ना, कि भाई ट्रांसल्यूमिनेशन है, which it and there is a decreased air entry, it is suggestive of that there is a pneumothorax and you have to put the chest tube. ठीक है, फिर अगला आता है कि there is antenatal history of the problem, मैटरनल USG किया है, फीटल MRI किया है, वहाँ पर मेंशन किया है प्रॉब्लम के बारे में, and there might be a respiratory distress at birth which can be present or cannot be present with decreased air entry on the affected side, and you have to take a decision on the invasive ventilation that you need to do, because बैग एंड मास्क तो कॉन्ट्राइंडिकेटेड होता है CDH में, है ना, तो आपको वो देखना है, आपको डिसाइड करना है उसके अकॉर्डिंगली. यू हैव टू डू द ब्लड गैस एनालिसिस एंड चेस्ट एक्सरे and whether there is a component of PPHN or not. So I'm going to discuss few papers also. So this paper is the time necessary to obtain preoperative stabilization, a predictive index of outcome in neonatal congenital diaphragmatic hernia. तो जब लोगों ने neonatal CDH को समझना शुरू किया, like in the beginning of this century, or I would say somewhere in the middle of the century, 1940 मतलब 20th century में, तो 1940 से लेके 1970 के बीच में लोगों को लगता था it's like a baby who is born with CDH, like taking him to the ORs, like rushing towards OR was the first step. They used to think that the diaphragm is the culprit or the intestine are the villains, that you have to close that diaphragm and the things will become normal. But with slowly understanding improved, pathologists analyze these specimens in the where there is a mortality. They found that the problem is not with the diaphragmatic defect or the amount of intestinal segments that are eviscerated into the defect. The problem is with the pulmonary hypoplasia and with the architecture of the pulmonary vasculature. So they have found that there is a pulmonary hypoplasia, there is hypertrophy of pulmonary vasculature, which is causing all these problems. And with time, people have realized that this is a physiological emergency rather than a surgical emergency. And then there are few guidelines, consensus come over the time. So here in this paper, they have discussed the 5 respiratory and blood gas derived indexes and the 4 hemodynamic and metabolic parameters. If you see closely, all these parameter and indexes that evolve around the pathophysiology of CDH. Okay, so you can see the oxygen index, the alveolar arterial oxygen gradient, the arterial alveolar O2 tension, then PaCO2. क्योंकि अगर आपका PaCO2 बढ़ा रहेगा, हाइपरकार्बिया वाला स्टेट होगा, तो it will cause vasoconstriction. And the PPHN will like do whatever it wants to do. And mean airway pressure, है ना, कि आपका एल्वेआर को खोले रखने के लिए कितना प्रेशर चाहिए, है ना. फिर हीमोडायनामिक और मेटाबॉलिक पैरामीटर्स. तो ये जो गाइडलाइंस, ये जो पैरामीटर्स हैं, ये जो इंडेक्सेस हैं, दे हैव डिस्कस्ड इन द यूरोपियन गाइडलाइंस ऑल्सो, इन द कैनेडियन गाइडलाइन ऑल्सो, है ना. तो नॉर्मल आपका मीन आर्टीरियल प्रेशर अचीव हो जाना चाहिए फॉर जेस्टेशनल एज, एंड दे शुड absence of right to left ductal shunt, urine output more than 1.5 ml per kg per hour, and the lactate blood levels below 3 millimole. तो इस स्टडी में उन्होंने देखा कि देयर वर 77 नियोनेट्स थे, जिसमें से 4 नियोनेट्स को बिकॉज ऑफ कंजेनाइटल हार्ट एनोमलीज की वजह से एक्सक्लूड किया गया. ठीक है, तो 73 बचे. एंड दे फाउंड दैट द 18 हैड मॉर्टेलिटी बिफोर द preoperative stabilization. So there were 55 left, and out of those 55, 33 had attained that optimization within 24 hours, and 22 attained it after 24 hours. फिर ये भी देखा गया कि उन बच्चों ने जिन्होंने विदिन 24 आवर अचीव कर लिया, उनका पोस्ट ऑपरेटिव जो स्टे था वो कम हुआ, उनको वेंटिलेशन की रिक्वायरमेंट कम हुई. तो ये धीरे धीरे अंडरस्टैंडिंग कब आई, व्हेन वी स्टार्टेड रियलाइजिंग एंड सीइंग a problem as a whole and not jumping into the problem कि भाई ये problem है, हमको इसको ठीक करना है और हम like it will sort out the thing. है ना। तो इस केस में यहाँ पर जो थी प्री सर्जिकल स्टेबलाइजेशन वाज अचीव्ड इन 75.4% of the neonates and overall survival was 72.7%, and mortality was seen in 11 in within 24 hours, 5 in within 48 hours and 2 in within 72 hours. Then उसके बाद आया कि एक पेपर है ये हमारे यहीं का ही है, तो इसमें पेरीनेटल आउटकम इन CDH सिंगल सेंटर एक्सपीरियंस डिस्कस किया गया, जहाँ पर 29 neonates थे over a time span of 3 to 4 years, and they have seen that all these neonates were antenatally diagnosed. All these neonates required mechanical ventilation or elective intubation. I mean the intubation because of respiratory distress at the time of birth. And it was found that the overall survival rate was 37.93, and the leading cause of death was severe persistent pulmonary hypertension. So this is the detail. You can see that respiratory distress requiring intubation in delivery room, it was associated with 100% of the neonates. And the survivors and non-survivors are discussed. Need for HFO ventilation, so 25, that is 86%. How many of them were in shock? So the 8 in the survivor group and 18 in the non-survivor group. And what was the day for surgery? In the survivor group it was 3, in the non-survivor group it was the 5. So ये भी देखा गया है कि कितनी जल्दी अचीव कर रहे हैं उस चीज़ को, है ना. Okay. And then the changing the outcomes of newborn with surgical condition at a tertiary level hospital in Kenya, a cluster randomized trial. तो यहाँ पर इस स्टडी में देखा गया, उन्होंने देखा कि अगर एक बच्चे को अप्रोप्रिएटली ट्रांसपोर्ट किया जाता है, एक न्यूबॉर्न को विद सर्जिकल कंडीशन, इट सिग्निफिकेंटली इम्प्रूव्स द आउटकम्स. तो इट डिपेंड्स अपॉन कि आपका मोड ऑफ ट्रांसपोर्टेशन क्या है. आप उसको प्राइवेट व्हीकल में लेके आ रहे हैं, आप उसको एम्बुलेंस में लेके आ रहे हैं, आपका व्हीकल कैसा है. एंड एस्कॉर्ट ड्यूरिंग ट्रांसपोर्ट, जब बच्चा आ रहा है तो उसको लेके कौन आ रहा है, वेदर इट इज़ एनी फिजिशियन, वेदर इट इज़ एनी पीडियाट्रिशियन और जस्ट द फैमिली मेम्बर्स ओनली, कि उनको बता दिया ऐसे करना है अपने, तो उस पर भी डिपेंड करता है. एंड व्हाट वाज द टाइम टेकन ड्यूरिंग ट्रांसपोर्ट, and what was the surgical condition and the status of hypothermia, hypovolemia and hypoglycemia, that you have to see. Then the congenital anomalies that present with gastrointestinal symptoms. So these babies can have abdominal distension, vomiting, increased salivation, but that we are not going to discuss. ये टैप मैं नहीं अब डिस्कस करूँगा यहाँ पे. And the failure to defecate and history and thorough clinical examination we have to do. तो vomiting एक कैसा है, whether it is a bilious, non-bilious, projectile, non-projectile, abdominal distension है कैसा है, proximal abdominal distension है या diffuse है, at the time of birth है या बाद में होता है, तो वो हमको देखना है. So this is the flow chart that I have used. So here you can see when in GI problems, usually there you might get a history of maternal hydroamnios, then you have to suspect obstruction of the GI tract. And if a neonate who is having abdominal distension at birth, it could be a very few reasons. Either it could be a meconium peritonitis, which could be of any cause, including meconium ileus, urinary ascites as with PUV in males, and hydrometrocolpos as in females in common cloaca. And it very rarely it can be a large abdominal tumor. And all other distensions start after birth when the child starts swallowing air. Then we have to clinically examine the baby. Okay, whether there is anal opening present or not. If it is not present, then you have to look for the signs which might suggest that there it is a low ARM or a high ARM. And depending upon, you have to do all those radiology imaging that you need. And then you have to rule out the EATF. Then you have to look for the OG aspirates, whether it is high or not, है ना. एब्डोमिनल डिस्टेंशन कैसा है, उसके बेसिस पर कितना ज़्यादा है आपके OG एस्पिरेट्स, है ना. यू हैव टू सस्पेक्ट अप GI ऑब्स्ट्रक्शन, है ना, कि वो फिर कंप्लीट है या इनकम्प्लीट है. हाँ, बच्चे के वाइटल्स कैसे हैं, उसके बेसिस पे आपको एसेस करना है ना. एट्रीसियाज कहाँ पर हो सकते हैं, कि वेदर प्रॉक्सिमल है, डिस्टल है ना, हर्शप्रंग्स है या मिकोनियम पेरिटोनाइटिस है, मिकोनियम आइलियस है. उसमें एक्सरे आपको मिलेंगे क्लासिकल. वी विल डिस्कस ऑल दोज थिंग्स इन द अपकमिंग स्लाइड्स. Then this study is from Lancet, where they have discussed mortality from gastrointestinal congenital anomalies at 264 hospitals in 74 low income, middle income and high income countries. It is a multicentric International prospective cohort study where they have included 560 patients, neonates with esophageal atresia, 448 neonates with CDH, 681 with intestinal atresia, and 453 with gastroschisis, 325 with exemplos, 991 with ARM, 517 with Hirschsprung disease. हाँ, so इतने कंट्रीज से इतनी जगह से ऐसे उन्होंने neonates लिए, and they have found that the chance of dying from a gastrointestinal congenital anomaly if born in low income country is 2 in 5. That means 40% mortality compared with 1 in 5 in a middle income country, that is 20%, and they have included India into a middle income country. And 1 in 20%, that is mere 5% in a high income country. And neonates born with gastroschisis have the greatest mortality differences, with mortality of 90% in low income countries and 32% in middle income countries compared to 1% in high income countries. Then this box and whisker plot is discussed. So they have mentioned that as I've already mentioned, that the middle income countries में बच्चा पैदा हुआ है, high income countries में पैदा हुआ है, low income country में पैदा हुआ है, तो वो एक होता है factor. Whether the neonate is having additional anomaly, whether it was antenatally diagnosed, whether the child was septic at presentation, whether the neonate was hypothermic or hypovolemic, whether what was the ASA grading, हाँ, फिर blood transfuse किया या नहीं किया. तो ये जो चीज़ें हैं ये डिटरमाइन करती हैं कि what will be the outcomes. You can read about this paper in detail. I'm not going to discuss the detail of this paper. Then we'll discuss problems one by one. So it's a late preterm neonate with a birth weight of 2.2 kg with progressive abdominal distension with bilious output from orogastric tube. And you did X-ray abdomen and you found there is the multiple air fluid levels with the one large air fluid level proximally. It suggests that there is atresia, intestinal atresia है ना. अब आपको उसको stabilize करना है जल्दी से जल्दी, and you have to post this baby or neonate for surgery. Okay. Then if you will see that this is a second neonate, 34 week 3 days, passed no meconium after birth, presented with gradually progressive abdominal distension associated with bilious vomiting. Clinical examination revealed distended abdomen with visualized bowel loop which are non-tender. Perineal examination normal था, आपने एक्सरे किया, आपने देखा there will be a disparity between the dilated bowel loops and there is no air fluid level. हाँ, और वो जो राइट साइडेड जो आइलियक फोसा वाला रीजन है वहाँ पर आपको ग्राउंड ग्लास अपीयरेंस मिलता है, सोप बबल टाइप का. हाँ, तो फिर आप सोच सकते हैं दैट इट इज़ मेकोनियम आइलियस, है ना. तो फिर आपको उस हिसाब से बच्चे को प्रिपेयर करना है. ठीक है. देन दिस इज प्रॉब्लम 3, ए क्रिटिकली इल नियोनेट विद लेथार्जी. हाँ, जहाँ पर जो कि आईसीयू में एडमिटेड है, प्रॉब्लम हुआ, उसको ब्रेस्ट फीड नहीं दे पाए, एंड द बेबी इज सिक ऑन वैसोप्रेसर, देयर इज मेटाबॉलिक एसिडोसिस, मार्क्ड abdominal distension है with abdominal tenderness, and there is absent bowel sound with increased gastric aspirate which are blood mixed and bilious. And you will do X-ray, you will find that there is pneumatosis intestinalis and there is portal venous gas also seen in there, but there is no perforation. So you have to manage these conditions with antibiotics, with upgraded antibiotics, with vasopressors wherever required. And there are few indications where if neonate is quite sick, whether you are going to do a laparotomy or you have to put abdominal drain. You have to decide at that particular time कि बच्चा कितना sick है. Then problem 4, progressive abdominal distension with absent anal opening in a 2-day-old male child and there is no history of meconiuria. And you have corrected dehydration, you have given antibiotics, you have stabilized the baby, and you are seeing that there is a disparity between the you can see there is a huge dilated bowel. So it suggests that there is a pouch colon. High आप वैसे ही देख रहे हैं आर में. ठीक है, तो पाउच कोलोन आप इससे आइडेंटिफाई कर सकते हैं. Then the problem 5, there is a low birth weight, 2.2 kg का बेबी है, late preterm है, eviscerated bowel loops हैं. There is always a risk of hypothermia, sepsis and dehydration, and you have to cover this bowel loops with saline soaked gauze and also baby, because आपने saline soaked gauze में कर दिया, वो फिर वो सूख जाएंगे, it will get dried up and it will cause more problem. antibiotics, IV fluids, and plan OT as early as possible. It has been mentioned in core and textbook of pediatric surgery that a review of more recent data indicates that a rapid transfer from the delivery room to the operating room, that is within 1 hour, will also lead to a greater likelihood of primary closure. And the delivery room and the pediatric operating room are in the same hospital. This is much easier to arrange. Then there are a few miscellaneous conditions. Cloacal extrophy hai. You have to do the care of extrophied bowel and bladder segment. And when you are looking for the ruptured myelomeningocele, you have to cover that thing. You have to avoid, you have to prevent the meningitis. Sacrococcygeal teratoma hai. You have to be aware of hyperdynamic circulation, whether there is a cystic component or a solid component. Accordingly, you have to act upon. And when there is extremity or cervicofacial swellings हैं, तो वहाँ पर congenital high airway obstruction syndrome KOs तो exit करने का ज़रूरत रहता है. So exit is ex utero intrapartum treatment. That is procedure done in fetal CPAM and KOs, congenital high airway obstruction syndrome. So it's a teamwork and a multidisciplinary approach is needed. Control cesarean delivery with maintained uteroplacental circulation, followed by securing airway intervention needed before clamping the cord. So the goal is to maintain oxygenation and hemodynamic stability via placenta and establishing ventilation or surgically relieving. So the exit to resection is needed very rarely. That means less than 5% of neonates. Usually it is managed with the intubation only at that time. So indication are giant CPAM जो कि पूरे आपके thorax को cover किए हुए हैं. If there is a severe mediastinal shift, hydropus fetalis अगर fetus survive करता है, and if there is a need for immediate ECMO or emergency thoracic surgery. So then there came a concept of bedside or bedside laparotomy or bedside surgery. So this paper have discussed about the bedside versus conventional operating room surgery, critically in newborns. We have discussed the systematic review and meta-analysis. Although bedside surgery was associated with a significantly higher mortality, in this paper that they have shown that there is 25.8% versus to 7.3%. The authors emphasize that this does not necessarily mean bedside surgery cause increased mortality. The bedside group was already very sick, generally consist of neonates who were too unstable, too labile to be safely transported to the operating room, making selection bias, confounding by the indication, a major limitation. So all these included studies were observational and there were no RCTs. Bedside surgery is a reasonable alternative for neonates who are in the cases where it's not possible to shift these babies or transport these babies to OR. Both approaches showed similar outcomes in terms of infection risk, post-operative hypothermia, operative time, and hospital length of stay if baby survives. Then the concept of neonatal bedside laparotomy in the UK. So they have also discussed that the major factors influencing this decision will include patient-specific, like cardiovascular instability, ventilator dependency, low birth weight, and respondent recalled complication associated with theater-based operating, including hypothermia, airway complication, and cardiovascular instability. So the concept of bedside laparotomy is widely accepted in modern neonatal surgical practice. The principal indication is physiological instability that makes transport unsafe, not the surgical diagnosis per se or itself. ठीक है, तो वो हमको पता होना चाहिए. Then also there is another paper operating within the neonatal intensive care unit, a retrospective analysis from a tertiary care center. So where it has been shown that the 13 critically ill neonates in which the median gestational age was 30 weeks and the median birth weight was in the range of 500 to 2860 gram. Range was 26 to 36 weeks, and they undergoing 22 bedside and NICU procedure, which includes ileostomy, bowel perforation repair, peritoneal drain insertion, gastrostomy, pilostomy, cystoscopy, and PD ligation by the TVS team. And it was found that the 1 month survival was 84% and overall survival was 77%, and no major post-operative complications and SSI was seen, and it demonstrated that the bedside surgery is a feasible and safe option for carefully selected unstable neonates. Then there are few problems with anesthesia related mortality in pediatric patients. So it was found that the mortality is more in case where there is a high ASA status when the emergency surgery is scheduled, when there is a significant comorbidities. So the review highlighted that the young age, poor preoperative condition, complex and emergency procedures are the major risk factor for anesthesia related mortality. हाँ, तो वो हमने यहाँ पर देखा. Then there are neonatal perioperative resuscitation protocol. It is an update where they have mentioned 7 domains which work around it, which include preoperative assessment, airway ventilation, circulation, temperature control, glucose, electrolyte management, analgesia, sedation. A good analgesia and sedation is a very important thing, and a post-operative care. So these all things we have to look after. Multidisciplinary care is needed to reduce the perioperative morbidity in high-risk neonates. So these are my references, Filston and Ejant, which was the first edition which came in 1978, and after the second edition came in 1986. It's very interesting and very good book. And then Cloharty, and then the NICU protocols from AIMS WHO collaboration. And thank you so much for listening, for the patient listening. I had a few interruption in between. Please pardon me for this thing. And this image I have taken from one book from the Alberto Pena, that is Monologues of a Pediatric Surgeon. Thank you so much for a patient listener. I'll keep discussing topics. Thank you so much.